okay? And they can first roll from uh, belly, okay, to back, because they are going to push with their hands, and they can roll from abdomen to back. But rolling from back to abdomen is a little later, around 6 months. Okay, around 6 months. Okay, it's explained there. And since without support at with support, sorry, at 6 months, unsupported 7 to 8 months. Crawl around 9 months, and also make pins with the thumb opposing the index. Holding cup around 12 months. And remember that in this first year, they have solitary play. Try to have toys that don't have small parts, because they take everything to the mouth. They explore the world through the mouth. Don't forget that their diet should be based in milk, breast milk, human milk, or formula. Uh, and around 4 to 6 months, you incorporate solid food one by one every week. For pain, you need to know the behavioral pain scales, like the FLACCIR or CRIS, that are the behavioral pains to determine the baby is in pain or not. When babies are in pain, they have tachycardia. A part of the alteration that you explore with these scales of pain that are used in babies, they are expected to have desaturation of the oxygen and tachycardia as manifestation of the pain. The separation anxiety, babies before 6 to 8 months, they can go with anybody that is in this position of holding there, okay? They get along, okay? But after 6 to 8 months, they start developing a normal psychological reaction, that is the separation anxiety. So they don't accept estranged people. So they need to be all time with their parents or grandparents, people that they know, okay? Uh, what you see here, what you see here is a summary of the most important aspect of the first year that, as I told you, is the most commonly tested in Nclex. And now that you need to learn this, but learn that, okay, with the idea of applying that into question. But you need some of you have a knowledge deficit of this aspect. You need to learn this. And know also the primitive reflexes. This is the motor reflex. All those are being in English, okay? This is the tonic neck reflex. When you turn the head of the baby in one direction, they extend the extremities in the ipsilateral, in the same lateral of the turning of the head, and flex the other. It's like a fencing position, no? Those people that use a spade to fight, no? The fencing position. This is the gallant reflex. When a baby is stroke in one side of the back, they flex the extremities of this side and extend the opposed. This is the grasp reflex. And this is the Babinski reflex. Babies, if they are placed in a solid surface, newborns, they can do this reflex. It's so funny because they seem to like they are walking, okay? And it's very funny, this reflex, okay? Um, yes, this is, okay. Those are the behavioral scales, as I mentioned before, that allow you to evaluate pain and in babies. In babies that are not able to recognize numbers or faces as manifestation of pain. So usually are used in babies that are, toddlers and infants, okay? So toddlers and infants, you even cannot use a, a face scale. They can understand or are dependable in interpretation of a face and the correlation with the level of pain. So is in those cases, we use a behavioral scale. We observe the child and we see how they respond. And then you have the face, legs, activity, crying, consolability, revised scale, which is the FLAC R. and the cries. Crying requires oxygen, increased heart rate, and expression sleepless. Okay, those are two. You don't need to memorize the skill, only to know that in babies you cannot use this, and you cannot ask a baby from 0 to 10. It makes sense, please. And obviously, those are the skills. Be knowledgeable about that. Okay, knowledgeable about this stuff. Those stuff are tested in English. You need to know that. Okay. Of course, they can ask questions about other ages. Okay. The Tanner stage, the most commonly tested, is the stage 2, when the breast bud appears, because this is what is concerning. Doesn't appear when there is a problems in the development of the females. This stage 2 is delayed. Okay, is delayed. Okay, so take care of this growth and development stuff that are, yes, are tested. Okay, and this is the application to this question. Okay, for example, now that you discussed that, you are going to be more competent answering this question. Finding required to follow up in a 4-month child. Head lag, bulging fontanelle when crying. Extensor plantar reflex, so Babinski, cannot roll from back to tummy. So what is the answer to this?
A.
A is an apple, okay? Because head lag after 3 months is concerning. It's not good. It suggests cerebral palsy. A baby, when is crying, is okay to see a transient bulging of the fontanelle in the moment that is screaming. So bulging of the fontanelle when crying is okay. When it is no good is to have bulging fontanelle when the baby is sleeping, or when the baby is eating or is playing, okay? Because it translates increased intracranial pressure. Extensor plantar reflex is the same as Babinski, and it persists until 12 months. And at 4 months, the baby can roll from front to back, from tummy to back, but not from back to tummy. It is going to take more control. No? So around 6 months is when it happens. Okay, so you see that this is the way that is applied to developmental questions. First year, the most important. The nurse is teaching an asthma patient proper use of the peak flow meter. The nurse determines further teaching is needed when observing which action by the patient. Let's see. Repeating the procedure for a total of 3 readings. Breathing in deeply through the mouthpiece. Standing while performing the test. Recording the highest reading of the peak flow sheet on the peak flow sheet after 3 attempts. What is the wrong stuff here? Are you lost? Okay, so let me refresh you a moment. Um, Remember that in asthma, the patient should be able to use this peak flow meter. Okay. 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 I want the visual. Okay. Shock. Okay. I want the visual shock. Okay. This is the baby, the child or adult using the peak flow meter. Okay. The peak flow meter. Okay. Peak flow meter is an objective method of determining how tight, how closed are the bronchi in an asthma client, especially during an asthma attack. If the pipes, imagination, guys, imagination, you need to go to Disney. Okay, if the pipes, the bronchi, are closed because bronchospasm, then the air cannot in and out. For the air to go out, first need to go in. So the patient, when using this device that is a measurement of the force, F-O-R-C-E-D, force, expiration, or force expiratory capacity, or force expiratory volume of air. The patient need to take air normally without the device, and then put the device in the mouth and blow with all his or her strength. And is going to measure until which level the marker reaches, okay? The normal grading or calibration is the word. Calibration of the device is made by the physician based in the size, age, and gender of the person. And when you blow, and you blow between 80 to 100, you are okay. The expected volume, okay? If your expected volume is 100 milliliters, to make it simple, okay? If you blow between 80 to 100 milliliters, you're okay. If you are between 50 and 80, okay, you are so-so. You need to use your rescue inhaler. So if you blow between 50 to 80 milliliters, you need to use your rescue inhaler. But if you blow less than half of the volume that is expected, okay, to blow, you are critically ill and you need to call 911, okay? And you need to go to the ER, okay? So this is the peak flow meter, and it's frequently tested, and you need to know that, okay? And don't, the people have were my students in contact, though, don't pretend, don't dare to tell that you never saw that, because this is the same PowerPoint slide that you had in my class, okay? And un segundito, yo aprendo segment eraser. Y esto que mismo. Just un moment. Y esto es stroke eraser. Lo mismo. Entonces, yo no sé para qué entonces. Ok, no, hablando solo. This is the peak flow meter. The peak flow meter, okay? Let me move. ¿Y por qué no lo puedo mover? No sé. Okay, the peak flow meter. I'm sorry, guys. Sometimes I have problems with the. Don't save. Open again. Okay. So peak flow meter is used by asthmatic clients. Okay, in those steps, move the marker to the bottom of the number scale. So this marker, this red marker, is going to be moved to the bottom. Okay, to the bottom. So it's going to be moved to the bottom. Stand up if you are able. Take a deep breath, filling your lungs completely. Place your lips tightly around the mouthpiece. Blow as hard and as fast as you can. Note the final position of the marker and document that. Blow 2 more times. The best of the 3 attempts is the one that you are going to use. You record the highest reading of the 3 blows. And the interpretation, I already gave that to you, okay? So this is what you need to know about peak flow meter. And if you have then in your Nclex a question like this, the nurse is teaching an asthma patient proper use of the peak flow meter. The nurse determines that further teaching is needed when observing which action by the patient. What is the answer?
B as boy.
B as in boy. So notice that we need to study. You're going to say Beijing, otra vez Beijing. Dios mío, yo que pensaba que me había librado de Beijing. Remember that nursing is a very demanding profession, that you're going to be dealing with human life. Remember that nursing is a study in the United States of America. The student first go to a bachelor of biology, then apply to a university, to a bachelor of nursing in university, and then if they have good grades in the previous bachelor, then is accepted in the nursing school. Not everybody is accepted in the nursing school, and then go to a bachelor, which is a program that takes near 4 years. And then when they graduate, they are going to go to sit in the chair that is at your side in the Nclex. So you both are going to take the same test, okay? The same test, okay? And remember that you both are going to be working with the same clients and the same places, etc. if you get the license, okay? So please remember that, yes, you need to know that, okay? So you need to study your peak flow meter if you have it not. And this is something that we already covered previously. The nurse administered a dose of ramipril 2.5 milligrams to a client at 9 a.m. While documenting administration of the medication, the nurse discovers that 1.25 milligrams, not 2.5, was the prescribed dose. The nurse assesses the client, completes an incident report, and notifies the physician and nursing supervisor of the error. What statement does the nurse add to the client's record? So what is the nurse writing in the client's record, in the chart, in the record, okay? So read the 4 documentations and tell me which one is the correct documentation.
B as boy.
B. B.
Yeah, as in boy.
The only person that I understood was a B. Um, the others I didn't understand anything. Okay. Yes. 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 No.
Yeah, we said B. B as boy.
Oh, B as in boy. Okay. And why B as in boy? Why? Because you gave twice, no, the amount.
Because too much detail. You don't have to
Opinion
give detail.
given
You
on
have,
B.
Okay. The term that they use for that is factual.
yes.
You need to document facts, not interpretations. Okay. And yes, you only document what happens, okay? You document what you did. You gave 2.5 milligrams at 9 a.m. You don't need to interpret anything, so you need to document only facts. Remember that the incident report is not mentioned in the chart, and please avoid, okay, documenting interpretations like C and D. But what is important to document is to add there that you assess the client, what you recommend the client. For example, this client should be recommended to stay sitting and avoid walking without help. And you should document that. The patient has been explained to avoid getting out of the chair or the jetty chair or the whatever without calling the assistant. And also you should document that you called the doctor and the doctor gave recommendations. So you document factual what happens, but then you need to document what you did for the clients and that the doctor was communicated, and it's important. But you don't mention incident report or nothing like this. The incident report will ask you other information that should not be mentioned in this chart. The clinical nurse explains to the nurse student that influenza is, se le da apply, seasonal, yes or not?
Yes.
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 Yeah.
So in which season is flu?
Fall, winter.
Winter and spring. That's why the vaccination is on fall. Okay.
Yeah, beginning September.
The vaccination starts on fall, but the high peak of the flu is winter and spring. Okay. Winter and spring, okay? So yes, it's seasonal, okay? It's seasonal, okay? If, okay, the vaccination should start before the peak of the season, okay? Is epidemic?
Yes.
Yes. Can be lethal?
Yes.
Yes.
Yes. It's prevented with vaccine?
Yes.
Yes.
Can be treated with oseltamivir, antiviral?
Yes.
Yes. So you can have perfectly a question in English select that apply with only one right answer or with all right answers. So notice that what never been is known, o sea, not answering any. At least one is answered, okay? The nurse knows that when the parents of a child obtains gratification and attention, making the child look sick is known as Malingering syndrome by proxy, hypochondria by proxy, Munchausen syndrome by proxy, borderline personality disorder.
Munchausen. C. C.
Munchausen syndrome by proxies are those people that make they are the people that they care of sick just to call the attention. It's a psychological problem. And it includes children, can include older people, can include pets, okay, etc. It's called Munchausen syndrome by proxy. Very frequently this question in the English, take care, okay? If you don't know that, learn, because you know you only need to know that this situation exists. You suspect, doctors suspect this when the person has very rare conditions that don't improve with the normal accepted or efficient treatment, and you know the tests are not concordant with the disease. Infection precaution in patients hospitalized with rubella. Going to an X-ray study. Request the X-ray personnel previously vaccinated with MMR. Prevent presence of pregnant women in the X-ray waiting room. Don't decline with a regular surgical mask. Postpone the X-ray study until the client is out of urban precaution.
C.
Yes, Kat.
Yes. The infection precaution, rubella is droplets. Yes, rubella is droplets. And which allow you to rule out the last option. Let's say this is in urban, okay? Don't confuse rubella with rubeola or measles. That is urban, yes. And the correct infection precautions is make the client don a regular surgical mask before leaving the room to go to the X-ray service. Yo lo que puedo hacer es esto y más rápido. Más rápido, ok. Okay, a client is receiving IV infusion of 10 milliequivalent per hour of potassium chloride and is required to go to an X-ray. What should the nurse do? Postpone the X-ray until the IV infusion finishes, turn off the infusion and restart when the clients come back. Activate the IV pump secured. Okay. Activate the IV pump and send the client to an X-ray with a CNA. Accompany the client accompany the client on X-ray while receiving the IV potassium. What is that? But if you have this question, what you choose? I'd like to know what you choose. This is the scenario. The patient receiving IV potassium must go to a procedure for some moment. What you do with this infusion?
Start the infusion.
I will turn it off.
B.
B as in boy.
Okay. Yes, I could discuss a lot of options, but definitively accompanying the client, the nurse accompanying the client to supervise the IV infusion implies like abandonment of the other clients that you have. So it is not a desired intervention. Sending the client under the responsibility CNA that you know that having the responsibility of checking for any alterations in the pump is not tolerable. And postponing the X-ray that is by the question is order is not in your scope of practice. So the best that you can do, because it's just an infusion of potassium, that is to stop the infusion, send the client for the X-ray, and when the client returns, restart the infusion. What is true is that potassium cannot be administered without supervision. Definitively. Signs and symptoms of infectious mononucleosis. Let's see, is a letter applied, yes or not, okay? Purulent secretions and inflammation of tonsils.
Yes.
Everybody knows that?
Yes.
Okay. So it's very difficult to differentiate mono from strep throat. Okay, and it is even, you see more inflammation in the tonsils in the infection mononucleosis than in the on strep throat. So those are okay. The tonsils of a person with infection mononucleosis is a very severe inflammation of the tonsils. This can reach the level of airway impairment. Okay, that is very rare to see in strep throat. Okay, because as you notice, it's touching tonsil with tonsils, and it's practical. It also, the patient have fever, maybe not so high fever as in the strep throat. The strep throat produces much higher fever, but the tonsils can clinically cannot be differentiated. You can make a test, okay, a rapid strep test to determine if there is a streptococcus there, okay, and also the mononucleosis have a blood test, okay, but it's very difficult to clinically differentiate one from the other, okay, so be aware of that. So yes, definitely yes. High-grade fever, no. I recommend not selecting that because it's not a high fever. It's a mild to moderate fever, no matter how seriously inflamed are the tonsils. Increase neutrophil leukocytes count. You know what neutrophils? You know that the white blood cells are the granulocytes on the agranulocyte. The granulocytes are eosinophils, basophils, and neutrophils, while the agranulocytes are lymphocytes and monocytes. The granulocytes increase mainly in bacterial infections. The agranulocytes increase mainly in viral infection. So do you expect in this disease increment of the neutrophils?
No.
No. You expect increment of lymphocytes and monocytes. Okay? So you don't mark that. Enlarged and painful neck lymph node.
Yes.
Super characteristic of the mono. Okay, very huge, painful and big, okay, lymph nodes in the neck. Swollen liver and spleen.
Yes.
Okay, so remember that if the spleen is swollen, there is risk of rupture. And remember that this disease affects mainly children, adolescents, and young adults that are physically active. So don't forget that teaching is necessary to prevent abdominal trauma. Very good. Doctor orders 2 milliliters intramuscular start of a medication for an infant. I said before that infant is considered less than 12 months. How should the nurse carry out this order? Are short. Read the options.
C.
Everybody agree?
Yes,
Okay. Yes, C. In vastus laterales, you cannot administer more than 1 milliliter. If 2 milliliters need to be administered, need to be divided into shots. So this is the correct answer, C. Doctor orders magnesium hydroxide with aluminum hydroxide PO every 6 hours and the antibiotic amoxicillin with clavulanate, this is augmenting, every 12 hours. How should the nurse administer the medications? Okay, so they say administer the antacid, okay, the Maalox, for example, every 6 hours, and the antibiotic 1 hour after the first and third dose of antacid. So doctors order the antacid 4 times, and the antibiotic is ordered 2 times. Okay, 2 times. Okay, so they say give the antacid every 6 hours, and then the antibiotic 1 hour after this and this dose. This is the first option. Consult with the provider to change the antacid for omeprazole. So avoid the Maalox and use omeprazole instead. Consult the provider to change antibiotic to parenteral. So the amoxicillin with clavulanate parenteral injected. Administer the antibiotic 1 hour before the first and third dose of the antibiotic. So administer the antibiotic before, 1 hour before the first and third dose of antacid. What is the best option there? This is A, and this is D. Okay, fasting, so empty stomach, sorry. Empty stomach is 1 hour before, 3 hours after. Okay. Based in the concept that you should know that antacids inactivate, bind and inactivate any other medication administered simultaneously need to be separated. So antacid cannot be given at the same time as the antibiotic. Cannot be given at the same time, need to be separated. The options that are here to separate is given the antacid first and the antibiotic later. So it is the option, this option, no? Antacid after, antibiotic after the antacid, okay? And the other option is given the antibiotic before the antacid, okay? What is going to fulfill the requirement of having the stomach empty without antacid when taking the antibiotic?
Yes, dog.
Exactly. Okay, so summarizing, don't get confused with these questions. If you have something similar, you need to give first the medication that requires empty stomach. Is the one that is given first, and then you wait 1 hour, and then the medication that can interfere. So the antibiotic first, and then 1 hour later, the antacid. This way, they are not going to mix. So fasting is 1 hour before, fasting or empty stomach, 1 hour before meals or antacid, and 3 hours after. Okay. This is a question of knowledge of nutrition. Food rich in vitamin A. Okay, bell pepper. You know what is bell pepper, okay? The answer is yes. For your information, it's very rich in vitamin A. Egg white, no. Sweet potato, yes. Spinach, yes. Apricot, yes. The only one that has no vitamin A here is egg white. The highest concentration of vitamin A is in liver, especially fish liver, no? Okay. Signs and symptoms of right heart failure. Crackles, yes or not?
No.
No.
No, this is left. Dependent edema?
Yes.
Yes.
Yes. Hepatomegaly,
Yes.
Yes.
congestive hepatomegaly. Neck vein distension,
Yes.
nocturia, peeing too much at night.
Yes.
Why the patient with right heart failure have nocturia? This is the patient during the day. How are the legs? Very swollen, yes? And this is the patient at night. What is doing with the legs?
They're raised, so the edema will go
Raised.
down.
And now, exactly, the liquid is going to be reabsorbed. And now participate in circulation and ends in the kidney, so the patient is going to be peeing this edema at night. This is the rationale for the people that have problem to memorizing that. Okay, perfect. Complications expected in people that use IV drug, cerebral apply. Hepatitis C, yes or not?
Yes.
Yes.
Thrombophlebitis,
Yes.
Yes.
of course. Of course. You are using the vein 3-4 times per day until there is a moment the vein is going to have thrombophlebitis. Apart that you know they are not using a very clean needles, no? Soft tissue abscesses, infections in the flesh. Okay, remember that those clients are, injecting in not very clean conditions, okay, frequently, no? And very frequently, okay, they develop, okay, abscesses, okay, in the site of the injection. You see that? Okay, so they inject and then they develop abscesses, okay, and makes sense, no? Makes sense. Okay, makes sense. So it's something that you find in those clients, okay? It's now that you visualize that, you understand, oh yes, it's true. Look at this person injecting through the abscess because it's the only vein they have, visible, is injecting the drug in the only vein that they find through the abscess. So now you understand how they inoculate bacteria in the circulation. No? Okay. Remember that it's an addiction. No? So no problem with that. Yeah. So if you enter bacteria in your circulation, what infection can happen in the heart? Endocarditis, no? You remember what is endocarditis, no? Okay. So endocarditis, bacterial endocarditis is one of the complications of that. Overdose, of course.
Yes.
Yes.
Hepatitis A,
No.
No.
okay. Female 25 presented 2 episodes of abundant hematemesis. Doctors order upper GI series. This is the barium swallow. What would the nurse assessing the clients, evaluate? So you are receiving the client that is going to have this upper GI series, is going to have this barium swallow. And you are admitting the client for the procedure while you assess, okay? Okay. Allergies to shellfish?
No.
No.
It's not pertinent. Dysphagia?
Yes.
Yes.
It's a swallow, it's a barium swallow. Last menstrual period?
Yes.
Yes.
Is going to have X-rays. If the client's MPO,
Yes.
yes,
Yeah.
because the stomach need to be empty to be filled with the barium. Okay. If any other abdominal test has been ordered,
Yes.
Yeah.
yes, because remember that this test interferes in any other abdominal test, ultrasound, CT scan, endoscopies, etc. Need to be left at last. Calcium with multiple myeloma. This is a form of cancer, very aggressive, seen mainly in older people, very bad prognosis. This cancer, multiple myeloma, has a very interesting characteristic. Okay, and is the severe, well, there is not something so impressive como allowed them to see. Okay, here I think it's impressive enough. The severe lytic or destructive lesions that this cancer develop in bone. So you see this hole in the skull, and it's the other hole, this. Okay, those holes that you see in the skull are the, look at how many has this client. Looks like a Swiss cheese. Are, ¿cómo se llama? The metastasis of this cancer in the bone. All the bones, not only the skull. Look at the destruction of the bones, okay? You see, they produce a lot of bone pain. You see the hole in the, ¿qué es esto? El femur, okay? You see the holes in the femur and produce a lot of pathological fractures, holes in the humerus, okay? And you know that bones have a lot of calcium. So if the bone is massively destroyed by this cancer, what happens with the calcium in the blood? Increases or decreases? Increases, because there is a shift of the normally present calcium in the bone to the blood, okay? So this is the reason for which they are talking about hypercalcemia here. So what do you expect the nurse, what the nurse expects to be being ordered in this client? Thiazide, parathyroid hormone, IV normal saline, calcium carbonate. What is the treatment of the hypercalcemia?
The parathyroid hormone,
Remember that the parathyroid hormone is going to be activated when the calcium is low. For example, you have a deficiency of vitamin D because you have malabsorption, or you have any renal failure in activation, lack of activation of that, and the calcium in the blood will decrease. No, this is the blood, and the calcium drops because there is no vitamin D or whatever. Yes, and then the parathyroid glands are activated. Okay, are activated. They produce parathyroid hormone, and the parathyroid hormone will scrape the calcium from the bone to put this calcium in the blood, normalizing the low calcium. The hormone that opposes the parathyroid hormone is the calcitonin. Calcitonin that is doing the opposite. Calcitonin takes the calcium from the blood and put this in the bone. That's why calcitonin is used in the treatment of osteoporosis. So don't expect that parathyroid hormone is used in hypercalcemia because it's going to make it worse. It's going it's not going to help. The problem of the hypercalcemia that need to be in your brain is that the hypercalcemia will damage the kidneys. Patient will develop acute renal failure because this severe hypercalcemia will produce a calcinosis in all the tubules of both kidneys and will produce acute kidney injury or acute kidney failure. And it's important to wash to flush the kidneys with fluids and diuretics. The diuretics that are used are loop diuretics because the thiazide diuretics elevate calcium in the blood, cannot be used. It must be loop diuretic like furosemide, bumetanide, torsemide, etc. Okay, so the answer to this question is liquid, liquid, liquid. When you have hypercalcemia, the answer in the test is liquid, liquid, liquid. Okay. Other medication like calcitonin, mitromycin, etc. can be used, but this is the specialized. Liquid, liquid, liquid is like when you have in your floor a lot of sand or dirt. What you do, you flush that, okay? You take the garden hose and then you wash your floor, okay? So that's it. This is the purpose of this question. But at least I want you to know what is multiple myeloma in case you have. And remember that usually this is the main complication of the multiple myeloma, apart that the bad prognosis cancer that it is. Client with lupus, okay, systemic erythematous lupus, has nephritis, lupic nephritis, which is the most serious, but it's a common and serious complication of lupus, and is receiving prednisone and cyclosporin. Cyclosporin is an immune suppressor, the same as the prednisone. Which herbal consumed by the client could interfere in this treatment? St. John wort, black cohosh, echinacea, and valerian root.
Echinacea.
I agree. Echinacea is used to elevate immunity. If the client has an autoimmune disease that should be suppressed immunity of immune suppressor, using an immunity stimulant is opposite to this purpose. Okay. St. John wort is a medication for depression that elevates serotonin. Black cohosh is a phytohormone, phytoestrogen, that is used for the treatment of hot flashes in the menopause. And valerian root is a sedative. How is monitored central venous pressure? More or less, how is the procedure of monitorization by a nurse of central venous pressure? Clients in semi-Fowler position. The zero of the ruler is the anterior axillary line. The central venous pressure is red when the column of liquid stops descending. The tip of the IV catheter must be in the subclavian vein. Anybody knows this? The answer of this question?
D as in dog.
D as in dog, no. So let me talk a little about, okay, the central venous pressure. Okay, so a person okay, has a heart, and the heart receives blood through the right heart, the right atrium, from the superior vena cava. It's called superior vena cava. The superior vena cava connects with the subclavian the subclavian vein here, the subclavian vein, and the subclavian vein connect with the axillary veins and with the jugular veins. So this is anatomy. So doctors and nurses can introduce a catheter or peripherally inserted or entering in the subclavian, but the tip must be in the superior vena cava. And here it says this is the tip.
Oh, yeah, that was the catch.
The tip is in the subclavian vein, and it is incorrect. So don't get confused in what is the tip. Okay, the tip must be in the superior vena cava. Okay, so the D as in dog should be eliminated. Okay, and you know that the pressure here, the pressure of the blood here, is useful because if it is low, it's because the patient has fluid volume deficit. It is high because the patient has fluid volume excess. You know that in nursing, it is measured in centimeters, more or less 5 to 10 centimeters of water. And once the patient has this catheter here in the superior vena cava, you can measure the pressure of the blood here in the superior vena cava, and it is called central venous pressure. And it's very easy. You are going to connect the catheter that is in the superior vena cava, no? The catheter is in the superior vena cava. This catheter is going to be connected with a tubing that has a bag of normal saline. Okay, this is normal saline. So all the tubing is filled with normal saline. But then you connect in a T connection, okay, another tube that is over a ruler divided in centimeters, you know? So what you see here attached to the pole is a ruler. And this ruler has connected in a T connection, a catheter, another tubing, yes, a tubing, yeah. And then everything is going to be filled with normal saline. So everything is filled with normal saline. You see that? Because the normal saline is coming from here. This is normal saline. But then you clamp, close, clamp the normal saline. And when you clamp the normal saline, no more normal saline is passing. You'll see how these liquid start descending, descending until stop. When this column of liquid in this ruler, in this tubing over the ruler stops, means that the pressure that is here, in the central vein, is the same as the pressure of this column of liquid, the pressure that is exerted this column of liquid. This is something that is taught to us by the professor of physics in high school, in secundaria, bachillerato, whatever you call that. And it's called communicating basis, okay? Communicating basis, or vaso comunicante, yes? It's a principle, a physical principle, okay? And then you read here, okay, at how many centimeters stopped the column descending, and this is the measurement of the central venous pressure. The zero of the ruler need to be in the mid axillary line. There is an anterior axillary line, a posterior axillary line, and a mid axillary line. This is the position of that, okay? And the patient need to be flat, Don't confuse this when you clinically evaluate the neck vein distension, that you place the patient at 45 degrees of elevation of the head of the bed, 30 to 45 degrees, to see the distension of the vein of the neck. This is different. This is the exact measurement of the central venous pressure with a very simple method, where only you need the central catheter placed by the doctor. Doctors in ICU could introduce a much more bigger catheter, central venous catheter, that enters inside the heart and continues through the pulmonary artery. It's called Schwann-Ganz catheter. It's pulmonary catheterism, but this is done by doctors. In those cases, the measurement is in millimeters of mercury because it's made by a computer. But this basic measurement of the central venous pressure using a ruler is a nursing, measurement that doesn't require too much technology and can be done in any environment, in a battlefield, in a catastrophe field, in ¿cómo se llama? In the back country, etc., etc. Okay. So client need to be flat. The zero is in the mid axillary line, and the tip of the catheter is in the superior vena cava. But the central venous pressure is red when the column of liquid stops descending. This is a question that had one student. Okay, how you measure central venous pressure in nursing? Of course, it's a question of that should be practicing in the lab. But if you understood my explanation, I think it should not bring too much problem too if something similar repeats. Remember that you can have a question that says application, no? The patient is ordered normal saline 100 milliliters per hour, and the central venous pressure is 18 centimeters of water. What do you do first? And the further you do, stop the IV fluid. Why? Because it's too much liquid, has fluid volume excess. And the second is to call the doctor to discontinue the IV fluid. It's another possible question, another question that have been in Nclex, where you apply the concept of central venous pressure. Are we good? Okay. What is the pathophysiology of type 2 diabetes mellitus? It's short, read that and give me the answer.
C.
C.
C as in cat.
Okay, C as in cat, insulin receptor resistance. Infection control in scarlet fever, drop the airborne contact standard only.
Droplet.
Droplet.
Droplets is the S of the Spider-Man. Doctors orders timolol to a client with open angle glaucoma. Which medical history could require clarification of the order? Diabetes, chronic bronchitis, hypertension, hyperthyroidism.
B.
B as in
B.
boy.
B.
Yes, bronchitis and asthma are contraindication of beta blockers, and timolol is the beta blocker. This is the answer. Okay, guys, those are questions that have been in English. Okay, some of you know this question. Diabetic client presents with acute presentation of diplopia, double vision. When asked to look to the left, okay, so remember that is the client left, okay? So it is right, and this is left. When asked to look to his left, the nurse observed this strabism. What diabetic complication could explain the finding? Macular degeneration, increase in intracranial pressure, left abducens, cranial nerve neuritis, left trochlear cranial nerve neuritis.
C as in cat.
Say again?
C as in cat.
C as in cat. Okay. Everybody agree? Yes, I agree with you. Okay. What is failing here when asking to look to the left is this muscle, the external rectus is paralyzed, and the most common is the sixth cranial nerve, the abducens, the one that abduces the eyeball is failing. Okay, here is okay, but here is failing. Yeah, and the one that has this in charge, the abduction of the eyeball, is the sixth, the abducens. So there is a left, okay, sixth cranial nerve neuritis. Complication of thyroidectomy, cellular apply, hypercalcemia, yes or not?
No.
No.
No, all the way around, hypocalcemia, because can damage the parathyroid glands. Recurrent laryngeal nerve damage.
Yes.
Yes.
And what produces that? How do you know that it happened?
The voice.
The voice, okay? There is dysphonia, okay? Bleeding, of course, any surgery bleeding. Laryngospasm, yes or not?
Yes.
Yes, that's why you need to have at the hand, okay, tracheostomy kit. Thyroid storm can happen after removing the thyroid.
No.
Yes,
Yes, if it's
yes,
partial.
yes, yes. It's one of the most serious complications of thyroidectomy. Yeah, can precipitate thyroid storm. Why? Because when they manipulate the thyroid gland, when they are removing the stored thyroid hormone can be released to the circulation, producing an acute hyperthyroidism, a thyroid storm. Yes. 28-year-old female with a history of photosensitivity and arthralgia presents with muffled heart sounds, neck vein distension, and hypotension. The nurse have prepared equipment for what procedure? Thoracentesis, thrombolysis, pericardiocentesis, automatic external defibrillator.
Pericardiocentesis.
Pericardiocentesis. This is the description of a person with lupus that is having a pericardial effusion with significant repercussion because it has hypotension and neck vein distension, has the Beck triad, no? Muffled heart sound, neck vein distension, and hypotension is the Beck triad that suggests cardiac tamponade, no? Okay, pericardiocentesis. Expected findings in a diabetes insipidus. Se les da apply. Okay, diabetes insipidus. Okay, so serum sodium 130. So it is 135 to 145. So how it is? Low. Okay, so it is expected?
No.
No, it is not expected. You expect the contrary. You expect hypernatremia because the patient is dehydrated, is wasting water in the toilet, and the sodium concentrate. Urine specific gravity, okay, is more or less 1.010 to 1.030 is the range, more or less, okay? So you expect this specific gravity?
Yes.
Yes.
Yes, the urine is very diluted because the abundance of water there. Urinary output 180 milliliters in 7 hours, yes or not?
No.
No,
No.
it should be
No,
more.
because of
More than that.
if they say per hour, okay, but in 7 hours, you know. Hematocrit high. Hematocrit generally is 3 times the hemoglobin. You have, I don't know, you have 13, okay, the hemoglobin, 14 hemoglobin, you are multiplied times 3. Okay, so it is going to be like 39%. Okay, 54 obviously is high. Yeah. So do you expect this hematocrit in a patient with diabetes insipidus?
Yes.
Yes.
Yes,
Yes.
because hemoconcentration, because the dehydration. Lung cancer diagnosis frequent in diabetes insipidus?
No.
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 It's
And the other
just
See ya.
bleeding.
weight loss is expected in diabetes insipidus?
Yes.
Yes,
Yes.
because the diuresis, okay? Well, at least you like it. You're good there. Okay. Diet in COPD. High in proteins and carbohydrate. Low in proteins, high in carbohydrate. Low in carbohydrate, high in proteins. Low in sodium and low in proteins.
A.
Hey.
A,
Low in carbohydrate and high in proteins.
I agree with you. Okay.
Yeah, sí.
So high in proteins and most of the patients are sick, but low in carbohydrate because carbohydrate transforms in CO2. Remember, the carbohydrates are metabolized in the mitochondria to ATP, heat, and CO2. So that's why they can have restriction in carbohydrate to decrease the production of CO2. Not always, but when there is a severe form. Okay, this is not a question. This is something that where you can be administered subcutaneous shot. Okay, you know that. Okay, the ventilator high pressure alarm goes off. The client is found restless on bed with O2 saturation in 78%. What the nurse does first, check for endotracheal tube kinking, assess by auscultation for both lungs ventilation. Ventilate the client with manual ventilation bag. Activate the emergency code. Okay, this is a difficult one. What you do first?
C.
A.
C.
B.
So notice that it is a a a letter soup. Okay. So all the letters are being mentioned. So is this client critical?
Yes.
It's critical. Okay, it's critical. What could be happening? We don't know. We don't know what is happening. Is this client requiring rapid intervention? Yes. Okay, so we have here a question that brings doubt. Can you alone solve the problem of this client? What do you think?
No.
Probably no. Yes. Probably no. We know that the reasons for having a high pressure alarm going off are several. Could be the kinking of the endotracheal tube, or could be other reasons, like for example, pneumothorax. Patients that are intubated with a tube and the machine is pushing air under pressure in the lungs can produce a collapse of one lung. When the lung collapses, the resistance increases because now the lung is not expanded, the lung is collapsed, and now the high pressure alarm will go off. Could be kinking of the tube, which is a bent endotracheal tube because misposition of the neck. Could be bronchospasm. Bronchospasm makes the resistance and the pressure needed to introduce the air increase. Could be blocks of flames. So there are many causes of having the high pressure alarm going off. So summarizing, we have first a patient critically hypoxemic. Second, a patient that probably alone we won't be able to rescue the patient. And third, several causes can be producing the situation that need to be assessed. But in this case, before assessment is needed intervention to improve the oxygenation of the client. Okay, so I have two assessments, A and B. But this assessment, both are assessment, both are the same, because strategies, I have the tendency of eliminating these two options, check for endotracheal kinking and assessing auscultation, because the client is critically hypoxemic and requires improvement of the oxygenation. So I prefer to be left between C and D. If I were taking my anchors and I had these questions, I'll do that. I know that assessment usually is the first that we do to know what is happening, but I already know without need of more assessment that this client is critically hypoxemic and critically critical, okay, critical. And I need to do something to improve the oxygenation. So for that reason, I cannot dedicate time to assess what is happening without first improving this oxygenation. Do you agree with this reasoning? That the reason for which I rule out A and B, the two assessment, because
Definitely.
at the ends are the same, are assessment. So if you work in the test, I always suggest you trying to rule out things that could be ruled out. So notice that both are assessments. So you suspect that because both are the same, both need to be done, both are assessment, and both assessment must be done. Probably this is not the desired answer, because when you have a multiple choice question and you have two options that are practically the same, you can rule out these two options by strategies. So you need to decide that if you first ask for help and then intervene, or if you first intervene and then ask for help. This is the conundrum. This is the to be or not to be, okay? The Hamlet, okay, situation. So this is the way that I would, presenting the question for me. Now, in my case, because training that I have is that I never attempt to manage critically ill clients without help. And they are asking me what I do first. So my inclination is ask for help, activate a code, which is something very rapid, and then go to ventilate the clients with manual ventilation bag with 100% oxygen. Okay, because obviously the machine is not providing the needed oxygenation, because the machine is saying, hey, I have problem. This is the alarm, meaning, and the auto saturation is low. But I don't know what you think, okay? Some of you maybe think that it's better to ventilate the patient. Well, then after initiating the ventilation, call for the code, which is going to be maybe difficult if the button of the code is far from the patient. I don't know. So this is what I suggest you to do in your test. At the end, you will decide what to do in your test.
Professor,
Yes, sir.
uh, in a situation like this, it can be really tricky because usually we know
Life,
as a nurse.
life is tricky.
I
The
mean,
life, the life
yeah,
is very
as a
tricky.
nurse, like you said, you've been telling us the first thing a nurse is supposed to do is assessing, and
I never said that.
I mean, in a case like this, what a nurse do, we assess, and then before we do any implementation but based on this one, it is very critical, like you said. So the patient really need help as soon as
And,
possible.
and which assessment to do, because both are assessment, A and B
Yeah,
assessment.
both of them are assessment. Usually we check to see if there is kinking in the tube. That might be the reason why the patient is restless and the oxygen is low. But like you said, since it's two assessment, you have to get rid of rid of both of them
Exactly.
because the patient is in need of
So it's
help.
a strategy that I suggest you to have in mind, because they are making it easier for you to rule out that. Because remember, assessment is the first in the nursing process. But sometimes they are giving you already in the scenario the needed assessment to intervene. If they are telling you that the patient that has an O2 in 78%, which is very low, uh, what more assessment you need? The patient is critically hypoxemic and the patient needs to be helped. Okay, so yes, is more assessment will be needed to determine exactly what is happening. But now the priority here, more than assessment, because assessment has been already given in the scenario, is to do something. The problem is what you do first. You ask for help, you activate the code, or you go directly to ventilate the client. Okay, and that's the position that I give you. Okay, so remember, in Nclex, this is going to be your situation. You're going to have a number of questions that you will be answered straightforward. Probably you will not remember those questions that you answer straightforward. Is what happened. People remember the difficult question. So now those questions are being answered relatively fast, and it is going to give you time, extra time, to dedicate to think this question that is more difficult, and just preparing you for what you are going to have the day of your Nclex, okay? So now you will obviously dedicate a little more time to think this question, to be careful, and then at least decrease the options, okay? Eliminating the one that can be eliminated, and then usually you are going to be left with two options that are possible, are correct. But then, because, for example, they ask you what you do first, you need to decide which one chronologically has priority. Okay, and then this is the way that you are going to analyze your questions to increase your possibility of answering correctly by the rule, by the book, the question. Make sense? So ahí se las dejo. Client has head trauma, which finding requires the nurse to follow up. So what is not expected here? Headache when sneezing, hematoma in right temporal area, urinary output 120 in 1 hour, dizziness when turning to side. Which one is not expected?
C, the urinary
C,
output.
the urinary output is exaggerated. It's too high. Usually you don't expect more than 60 milliliters, 70 maximum milliliters per hour, even when you are very well hydrated. So it is an exaggerated urinary output, suggesting that the trauma could have impairment of the pituitary gland, the posterior lobe of the pituitary gland, producing diabetes insipidus. Good. Client, 70-year-old diabetic and ex-smoker. Old, diabetic, and smoker. Has all the conditions to have a stroke, to have myocardial infarction, or to have peripheral artery disease. After cardiac catheterization, the client is seen with a compressive dressing in the right femoral area. So remember that you in those clients going to cardiac catheterization, you are not going to be present in the catheterization. You receive the patient after the catheterization, and you need to take care of the client in the process of recovering after the catheterization. So the client arrived with the dressing in the right femoral area. Yeah. What should be something to follow up? What should be something that is not expected? Pain in right groin, numbness in right leg, pedal pulses symmetrically decreased in both feet, difficulty to void in flat position. What is concerning you?
C as in cat.
It's pain in the
C
right groin.
as in cat
B.
is B as in boy is my concern. C as in cat is expected. It's a trap. It's something that you should not be following this trap. If you have a person 70 years old, a smoker with diabetes, both arteries are going to be partially obstructed. Both pedal pulses are going to be decreased. You cannot avoid that peripheral artery disease in a 70 years old diabetic and a smoker. What you should be concerned if in the right leg, the pulse will be more, decreased, weaker than in the left or absent. So asymmetry is what makes you the concern, because the manipulation was made only one artery. So immediate consequences of this manipulation is what should concern after the procedure. What is present from forever is not your concern. You cannot change that. You understand? So that's why it is a trap. Symmetrically, symmetric means that both sides are the same. Decrease, okay, pulses is something that is expected in this client. Is expected. So is not C, definitively not C.
Thinking in hematoma could be a pain in the right groin, I think.
A pain is
Expected too, right?
something that is expected when you have an incision with stitches now or staples and a puncture, and you have a closure device there and a compressive dressing. Okay, so pain okay, unless it is a severe excruciating pain that doesn't improve with analgesic, is something like, you know, to observe, but it's not the most concerning. Ahora, why you have anesthesia in the right leg? Because they give local anesthesia in the skin, but not in all the leg.
They pick in a nerve.
Okay, so you need to suspect that now your hematoma is compressing the nerve. Okay, your hematoma now makes sense. The hematoma, more than producing pain, is compressing the nerve, producing numbness. So probably the most concerning here is the numbness, not the pain, because pain could be or not a problem. But the numbness definitively is not expected in this procedure. This is the rationale that I apply to this question. Guys, if you want to intervene, you can intervene, no problem, okay? ND has just practiced lumbar tap in a client with ischemic stroke. This is not done anymore. What order should the nurse clarify? Just practice lumbar tap. What order you clarify? Nimodipine, enoxaparin, metoprolol, normal saline. Okay, I want all of you.
B.
You say, I have hearing problems, but apart of that, the transmission of the sounds in the system is not the best. When you see
B as in boy.
B as in voice is clearly okay. I agree with B as in boy. You need to learn something, guys. The manipulation with lumbar tap or surgery of the spine is contraindicated in presence of anticoagulants. Not only strong anticoagulants, even aspirin and clopidogrel, because the risk is too high. Okay, remember that you have, okay, in the spine you have this cord and those nerves that go in the medullary canal that is formed by the apophysis of the vertebrae. If any trauma occurs here, like a lumbar tap, and the patient is having anticoagulants, bleeding can occur, producing a hematoma that can compress the spinal cord or the bunch of nerve, the cauda equina that you have there, and as a consequence, the patient will develop paralysis of the lower extremities, which is called paraplegia, and malfunction of the bladder. The sphincters are going to have malfunction, and it is very sad that because, you know, allowing the patient to receive anticoagulants when there is a wound in the spine, something so dramatic can occur. So anticoagulants, aspirin, clopidogrel, etc., are contraindicated if the patient has either surgery or puncture in the column. What must be removed before an MRI? Earplugs, Klein's gown, nicotine patch, oxygen cannula.
Earplugs.
Earplugs.
C and I use me. Okay, the answer is C, as in cat. Okay. Because there are several patches that have metallic layer, and for that reasons are going to interfere in the MRI. It's going to produce defects in the image. Okay, it's going to produce artifacts in the images. So the nicotine patch need to be removed. Earplugs are rubber, gown is ¿cómo se llama? Cloth is cotton, and oxygen is plastic. They don't interact with the magnetism. What is true for the MMR vaccine? is administered intramuscular in vasolaterales, should be administered after 12 months of age, cannot be administered if the client is allergic to penicillin, cannot be administered to childbearing age women.
B.
B as in boy.
B. D as in David.
Okay, remember that you are a childbearing woman, but you are not pregnant. Okay, so childbearing age is a woman that has the potential of becoming pregnant, but not necessarily is pregnant. So take care with the terminology. Yeah, childbearing age doesn't mean that you are pregnant. So clarify that. Precisely, the people that should most receive this vaccine they have not yet received before is the childbearing age women to prevent the rubella in pregnancy. Okay, so childbearing age women should receive the vaccine if have not been vaccinated before, precisely because our childbearing age. Okay, but pregnant women cannot receive that because it's a live viral vaccine. Yeah, there is no relation between penicillin allergy and that. And it's a vaccine, the live viral vaccines are administered subcutaneous, not intramuscular. So the answer is B as in boy, okay? Must be administered after 12 months of age. For you to remember this, generally babies are going to have the mother antibodies, the antibodies of mama, okay, in his or her blood, okay, until 1 year. Okay, so mama passes antibodies to babies, okay, until 1 year. Remember that mama is an adult. Mama has already or suffered the diseases or vaccinated against the diseases. So mama is immune, probably immune against these 3 diseases. If mama has antibodies against these 3 diseases, and those antibodies are passed to baby, when a live vaccine is given to baby before 1 year, when those mama's antibodies are already present in the baby, the antibodies are going to kill the vaccine. And the vaccine is going to be like water. It's going to be like injecting water. It's nothing. That's why they need to wait until 1 year for those antibodies that are transferred by mama wears out, disappear, to then vaccinate the baby. This is the rationale for that, so people remember that, okay? But don't confuse childbearing age with a pregnancy. Which vegetable should be limited in a patient taking warfarin? Asparagus, avocado, potatoes with the skin, with winter squash.
Avocado.
Avocado has no vitamin K.
A.
Maybe the leaf of the avocado.
Asparagus.
Maybe the leaf of the avocado has vitamin K, but the avocado has no vitamin K. The green leafy vegetables, so the leaf of the edible leaf of some vegetables are the ones that are usually rich in vitamin K. Remember that in Nclex, vitamin K is called phytonadione. Okay, phytonadione. Okay, don't get surprised if they say mention phytonadione. Okay. And of these 4 stuff, the one that has these characteristics is the asparagus. So vitamin K is in the asparagus. The student who had this question passed the Nclex, but he also selected avocado. But you can investigate. Avocado is not rich in vitamin K. Asparagus is, yes, rich in vitamin K. Okay. It confirms what I've been telling people. You don't need to have 100 to pass the Nclex. You can fail questions as far as you don't kill anybody, okay? You can fail questions and still you can pass your Nclex. What the supervisor nurse found wrong in a dressing change of a central catheter for total parenteral nutrition. So what is wrong here? Nurse wears clean gloves to remove dressing. Nurse cleans the catheter with chlorhexidine, which is the good antiseptic, up to the insertion site. Nurse doesn't apply antibiotic ointment to insertion site. Nurse leave the insertion site exposed to air until chlorhexidine dries. What is wrong here?
C.
Okay, there is no recommendation. There is no recommendation of applying antibiotic ointments in central catheters because can promote candidiasis and candidiasis, sepsis by candidiasis. So when you change the dressing of a central catheter, you don't need to administer a triple antibiotic or any antibiotic in ointment there. It's not used. It's not used. Basically, what is done there is to remove the old dressing, clean in the proper way from insertion away, with chlorhexidine, allowed to dry, and put a new dressing. This is the basically what you do in. So you said B. What you said? Oh, A.
A.
Huh? Can you repeat?
I say A.
A as an apple. Okay, it is correct. It is correct. You have a patient that have been for 3, 4, 5, 7 days with a dressing in his or her chest. And this is the old dressing. This dressing must be removed to then clean the catheter, okay, and the insertion site. To remove this dressing, you use clean gloves. You don't use sterile gloves. This dressing is not sterile. Outside, this plastic that is here covering, okay, the tube and this is outside, is not sterile. So you are going to be wearing clean gloves to carefully remove this dressing. You do not touch, okay, the insertion site, nor the surrounding skin, nor the catheter with those gloves. But to remove this old dressing, okay, you use clean gloves. Then after you remove the old dressing without touching here, you are going to observe the site. You are going to sanitize your hands, and then you are going to open your sterile kit, and then you are going to don the sterile gloves that comes in your sterile kit. So now with the sterile gloves, you take the applicator with chlorhexidines and start cleaning from the insertion site away, scrubbing energetically in the way that has been taught to you that must be done, the cleaning. And then you are going to wipe the catheter that is covered, but you need to wipe not up to insertion site. No, up to insertion site. No, it's going to be away from insertion site. Okay, so there is something wrong here. Let me go again to. Okay, there is something wrong here. Okay, that is that the nurse is cleans the catheter with chlorhexidine up to insertion site. Is wiping the bacteria. This is insertion site. Is wiping the bacteria from the dirtiest part to the insertion site. Make sense for you? Okay, so this is what is wrong here. The rest is correct. Clean gloves to remove the old dressing. Remove the old dressing is okay. Okay, a sterile glove to put the new dressing, to clean and to put the new dressing, but sterile gloves, but clean gloves to remove the old dressing. Okay, you don't apply antibiotic ointment. And it's important that the chlorhexidine kills the bacteria when drying. The same as alcohol, when you use hand sanitizer, you need to dry in your hands. In the moment that alcohol and chlorhexidine dries, okay, is when the bacteria desiccates and die. So it is correct. You leave the site exposed to air until chlorhexidine dries, and then you cover. You don't blow, you don't fan, okay? It's just on this way. But you don't clean up to the insertion site because, ¿cómo se llama? You are sweeping the bacteria to the point of entrance of the catheter, which is not good. And exactly with this wording, okay, was the question one of my students. Nurse is teaching use of incentive spirometry before surgery. It is different. It is not the same as the peak flow meter. Peak flow meter that I explained today earlier is a test to evaluate, to assess, to measure how much air a person with asthma can blow. Asthma or COPD or even Guillain-Barré or any condition that produces impairment of the ventilation, moving the air in and out. But the incentive spirometry is something used as a treatment. It's a treatment, it's not a testing to prevent atelectasis. Yeah? And is used in hospitalized clients, especially after surgery, after general anesthesia. Okay, so what is the correct instruction? Breathe in and out through the mouthpiece, breathe in through the mouthpiece, blow through the mouthpiece, breathe in through your nose, and breathe out through the mouthpiece. What is the right answer?
B as in boy.
C. Breathe
B.
through your nose
Breathing.
and breathe out through your mouth.
B.
Should be C.
Okay, so remember that when you're using the incentive spirometry, you're going to sit the client, this must be sitting, and you are going to ask the client to empty the lungs, and then when the lungs are empty, to place the mouthpiece in the mouth, very well sealed with the lips, and then the patient will breathe in while observing in the cylinder of the incentive spirometer how high can ascend the marker that will psychologically incentivize the client, okay, to breathe each time deeper and deeper. After the client fills the lungs with the air and measure the air and visualize the amount of air that enters the lungs, remove the mouthpiece from the mouth, of course, hold the air for 5 seconds, and then breathe out, okay, through the pursed lips, not through the mouthpiece, through the pursed lips, okay? So this is the technique of the incentive spirometry. When the option, okay, there is a mistake here, I to see, okay, vamos a ponerle aquí D, okay? Option D, say breathe in through your nose. No, you breathe in through your mouth. Breathe in through your mouth and through the mouthpiece. And breathe out through the mouthpiece. No, you don't breathe out through the mouthpiece. So D is incorrect. You don't blow. This is not a trumpet. This is not a whistle. So, and you don't breathe in and out. It's not through the device. No, you only breathe in through the device. Okay, and then when you finish breathing in through the device, you remove the device, hold a little the respiration, and breathe out through your mouth, your normal mouth, okay, through pursed lips. The answer is B as in boy. This is the correct use of the incentive spirometry. Okay, very important, very important. The nurse observed lasagna and sugar-free cherry gelatin in the food tray of an Orthodox Jewish client hospitalized for diabetes mellitus. What should the nurse do? What is the answer to this question?
D, of a diamond.
Return the tray to the kitchen and make the dietitian contact the client's rabbi. Correct. This is the correct answer. Okay. All this food is contaminated. Lasagna is a no-no, and gelatin is a no-no. Lasagna because lasagna combines meat and dairy, and gelatin because could have pig feet. Okay. So it's not enough removing the cherry gelatin. Need to be remove all the food, all the tray. Everything is contaminated for their purposes. Okay. EKG yes, ma'am.
In the previous question, you said, why would you contact the client rabbi?
Oh, because the rabbi needs to supervise that the food is kosher. All the kitchens that are kosher should be approved by the rabbi. This is interesting to know. It's an interesting question and interesting to know. So you cannot expect a Orthodox Jewish client, patient, accept your food because you say that is kosher. Need to be certified by a rabbi. And yes, need to go the rabbi certify that. Okay. For example, if it's an Orthodox Jewish family are going to have a bar mitzvah is like a ceremony in I don't know, in a banquet hall. The rabbi need to come and cover all the kitchen with foil and brings the pans where they are going to cook the food that is going to be served in this bar mitzvah. Okay, is complicated, but summarizing. Okay, return the tray to the kitchen, and the dietitian need to be in contact with a rabbi to decide how this patient is going to be provided with kosher food.
Profe,
Mm-hmm.
what did you say that the gelatin has that they cannot eat?
Paticas de cochino.
Oh, okay, thank you.
Because you know gelatin
Yeah,
can be
gelatin, yeah,
done with collagen, and the collagen is obtained of any animal that have collagens, and usually the cheapest is the feed. No, it is going to be
Yes.
boiled and obtain the gelatins, and then they dry that, and they supply this dry collagen to all the factories that do that. That's why gelatin is an excellent source of protein. An excellent source of
Thank you.
protein. A la orden. EKG monitor in nursing station shows asystole. What? Ajá, esta se parece a aquella. What you do first?
C.
Very good. Very good. I don't know if I discussed that with you, but there are many questions about systole, asystole. Okay, guys. There is a lot of questions about asystole in English. You need to know that asystole is when the monitor you see a flat line. But the problem is that it depends where the monitor is. In telemetry, sometimes the monitor is far from where the place the client is. So maybe the client is here, the client is here in a room, and the monitor is in a nursing station or in a monitor control room, etc. Okay. And remember that clients must have electrodes attached to the chest, okay, and connected with cables with a device that is transmitted tetherless, is transmitted wireless, the information to the monitor. Sometimes there are monitors that are connected directly wired to the wired monitor, but the most common is not wired, is wireless, is telemetry. Okay. So when you see a monitor, okay, a flat line, you need to pay attention to the scenario of the question because they are different possibilities. So if the monitor is wired and you have the monitor at the side of the patient, okay, the first that you do is to determine if this flat line is true or false. And this is what makes different the asystole or flat line from the other dysrhythmias like the ventricular fibrillation or the BTAC. Okay, because BTAC and ventricular fibrillation cannot be false, it's always true. This image cannot be confused with any other. Ventricular fibrillation and BTAC always is true. But asystole could be true or false. The reason for that is that if the patient is having a derivation, suppose D2, okay, and one of the two cables needed to register D2 false, separate, disconnect from the client, then you are going to see a flat line in the monitor, but it's just because the cable fell. It's not because the patient is in a real asystole. The patient can be watching TV. If you are at the bedside and it's a wire monitor, the first that you do is to check for responsiveness and the status of the cables before calling for a code, because you should not be calling a code for a failed cable. Make sense? When the monitor is at distance, so you are far from the client, the practical approach is to remember that those monitors have a button that allows you to choose different derivations. And each one of these derivations use different cables. So usually, the cable that will fail, if it is the situation, is only one. So moving the button from one derivation to the next, then you can reobtain the rhythm. And you say, oh no, the patient is alive because it has a rhythm. Okay, is having a flat line in D1 because the cable of D1 fell, but I have a rhythm in D2. So there is no need of calling a code. You just solve the problem of the falling cable. Yeah, understand? So, but obviously everything depends on the scenario. I seen all those scenarios in Nclex, but in the case of asystole, it's very important that the first that you do is to be sure that it is a true asystole. A true asystole. If it is a true asystole because the patient is unresponsive or the cables are not falling, then you activate the code. It's different when it is a BTAC or ventricular fibrillation. This is no need. You activate the code independently if the patient is responsive or not, because you need help. You first ask for help and then go to attend the client. The sequence of approaching a client with a life-threatening dysrhythmia is first recognize the problem. And generally, you recognize the problem in the monitor. For that reason, they put you the picture, the graphic of the rhythm, because this is the first recognition of the problem, recognition of the rhythm. Second, once you recognize it is a life-threatening rhythm, and usually the most commons are BTAC and ventricular fibrillation. The second is ask for help. Don't pretend solving the problem you alone. You are going to kill the client if you delay the activation of the code, because the activation of the code is what we're going to bring the defibrillator, the crash cart, and the people that are trained in advanced cardio life support. Once you ask for help, you determine if the client has or not pulse, carotid pulse. And if the pulse is absent, you start chest compression, chest compression. This is the 4 steps that you need to know perfectly in this sequence and in this order in case of life-threatening cardiac dysrhythmia. Recognize the problem, and they are going to give you in the questions a monitor recording. Activate the code, which is the same as asking for help. Determine if there is pulse, and if there is no pulse, start chest compression and wait for the people to come while you deliver chest compression. But there is one rhythm that brings a problem, and is the asystole, because asystole could be real, which is a super life-threatening condition that requires all these steps that I mentioned here, but it could be false. And it's false when there is a client that has a cable which fell. In those cases, you need to quickly determine it is a true or false or asystole. If you are at the patient bedside, if you are near the patient, assess for responsiveness, assess the cables. Either option could be present. It's the same. And of course, if you see that it's a real asystole, the patient is unresponsive or the cables are in position and the patient is unresponsive, then you go to activate the code, check for pulse, and start chest compression. Okay? You are at distance, you are not near the client, and it's going to be a waste of time to be running onto the client's room. You can quickly know if it is a true or false asystole, changing the derivation that you are observing in the monitor, just moving a button. If you regain rhythm, okay, in one derivation there is a flat line, but in the next derivation you have PQRS. PQRS, it is a falling, okay, falling cable. Makes sense? All these details have been tested in Nclex because it's a real life situation. Remember that you are going to take a test for an entry-level generalist nursing, and what is required for an entry-level generalist nurse is these 4 steps of the CPR. No advanced cardio life support. Only these 4 steps. One, recognition of the problem. 2, knowing that the first to do once you recognize the problem, you identify the problem, is ask for help. Don't pretend solving the problem alone, because it is going to be an unnecessary delay of time for the people who know, and the defibrillator and the crash cart to come to the client. And then after you ask for help, check if there is need of chest compression. How do you know if there is need of chest compression? Because the carotid pulse is absent. You should not give chest compression if the carotid pulse is present. Okay, that's why first you check for carotid pulse, and then you start chest compression. I agree. If I were having my test and I see a monitor showed, asystole, what I do first is check if it is a true asystole or not. A true asystole or not. But then remember, each question have many different versions. Versions that are real, plus the version of the different interpretation of the person who left the test and give us the information. So play with all these possible options that I mentioned before. Lisino previous prescribed to a client. We finally require the nurse question in the order. Potassium 3.2, A1C 11, T and tall and peak T wave in the EKG, chronic bronchitis.
Should be C.
C.
Should be
C.
C because of the hyperportacemic.
Exactly. This patient has already high potassium, and lisinopril elevates potassium. So renal failure, presence of renal failure and or hyperkalemia contraindicates the use of ACE inhibitors and ARBs. So anything that is pril or anything that is sartan cannot be used if there is already renal failure or if there is already high potassium. A T wave, okay, PQRST, okay, a T wave that is tall and peak translate high potassium, okay, high potassium. A part of that, the P wave will be flat, the QRS will be wide, okay, and then you have the T wave, okay, okay. Don't get confused, okay. Okie dokie. Low potassium is not contraindication for pril. Diabetes, uncontrolled diabetes, is not contraindication. By the contrary, if the patient has not yet renal failure secondary at the diabetes, the ACE inhibitor will protect the kidneys of diabetic clients. Chronic bronchitis is not contraindication for pril. Beta blockers is the contraindication in chronic bronchitis. Another similar question, another student. Lisinopril is prescribed to a diabetic client with laboratory findings required questioning the order, and here you have the elevation of the creatinine. So creatinine elevated suggests renal failure. Patient with renal failure should not receive ACE inhibitor. High glucose is not contraindication. Proteinuria, it is going to benefit if the patient receives lisinopril because will improve the proteinuria. Proteinuria doesn't mean renal failure, but elevated creatinine, yes, means renal failure. And which test is this? For what is this test? The B-natriuretic peptide or BNP. For what is this test?
Heart failure.
Heart failure.
Heart failure. This test elevate more than 100 when it is heart failure. Usually much more than this. Usually in the 2,000, 3,000, 5,000. Okay, very high when there is heart failure. But as the patient control improve his or her heart failure, it starts dropping until normalizing. Having heart failure is not a contraindication by the pril. By the contrary, the ACE inhibitors are cornerstones in the treatment of heart failure together with diuretics. Diuretics and ACE inhibitors are the life-saving interventions or treatment in heart failure. Much, much more important than dioxin, okay? Okay, EKG again. The nurse from OB obstetrics is floating to med-surg. So the OB nurse floats to med-surg. And you have 4 patients with cardiac dysrhythmias. Which client you assign to this floating OB nurse?
B.
Exactly. B as in boy, because it is an atrial fibrillation. Atrial fibrillation tends to be chronic in the majority of the cases and are going to be treated with oral medication. This is a Torsada point, this is a BTAC, both are BTAC, and this is a supraventricular tachycardia. Those are unstable clients. This is the most stable client, the atrial fibrillation. Atrial fibrillation usually are taking 2 medications. One to slow down the heart, could be beta blocker, could be calcium channel blocker like diltiazem or verapamil, could be dioxin. Dioxin, calcium channel blockers, the non-dihydropyridines, the diltiazem or verapamil, and beta blockers slow down the heart. It is called chronotropic negative. Chrono negative. Okay, the chrono negative are beta blockers, calcium channel blocker, but not all, the diltiazem or verapamil, and the dioxin. Okay, those are the three that you need to know that are chrononegative because slow down the heart rate. But the other medication need to be taken is an anticoagulant to prevent the formation of clots inside the heart. Both medications are given orally and probably lifelong because the 97% of the atrial fibrillations are chronic, cannot go back to normal sinus rhythm. Client admitted with MI 12 hours ago. Is acute, is fresh. Which finding requires to be communicated to the provider as soon as possible. Lab report troponin level 10 times normal value. Pronounced ST segment elevation from B3 to B6. Occasional PVCs, premature ventricular contraction near T wave of precedent complexes. Blood pressure 140/88, a little high. What of this must be communicated immediately to the doctor? 3 a.m.
C.
C.
The C as in cat is because PVCs in myocardial infarctions are very, very risky, can precipitate in any moment ventricular fibrillation. And especially if the R on T phenomenon is happening. R on T phenomenon is when the PVC is near or over the precedent QRS complex. So when you see, for example, PQRS, and then you see a PVC coming very near, no? Very near. You see a PVC, big, bizarre, okay, falling. This is the PVC. This is the normal PQRS, the previous complex. The PVC very near the T wave. I draw the T wave here inverted because the patient is having an acute myocardial infarction. Then this is a need of immediately report because in any moment the patient can have a ventricular tachycardia, ventricular fibrillation. Doctor will suppress, stop, inhibit those PVCs with medication. Usually amiodarone, okay, or dronaron, but also the old-fashioned lidocaine can also be used. Lidocaine or amiodarone or dronaron are used in the control or inhibition of these PVCs, of those undesired PVCs. With finding in diabetic line, taking rosuvastatin, so the statin, requires immediate follow-up. Read the force. Which one is the most concerning?
C.
Muscle weakness. I agree. The worst that can happen with a statin is the rhabdomyolysis. Rhabdomyolysis is a myopathy, a damage of the skeletal muscles in all the body that breaks down the muscle cells, releasing the myoglobin, the protein that is inside the muscle cell, to the blood and to the kidneys, and appears in the urine as myoglobinuria. So the urine becomes a brown, reddish brown, and it is very bad, terribly bad. This is something that is very bad, okay? And it's a complication that can occasionally, rarely, but occasionally happens in patients taking statins. The early manifestation is muscle pain, muscle, not joint, no bone, muscle, okay? Soft tissue, muscles, pain, and muscle weakness to come, to get up of a chair, to climb stairs, etc. And when it happens, doctors order to discontinue the medication and determine a blood test called CK, creatine kinase in the blood. And it usually is very elevated. It is the worst complication that can happen of the use of a statin. It's not common. This complication is more frequent if the client has the bad idea of taking grapefruit juice. Grapefruit, okay, use. And that's it. The other complication is the hepatotoxicity, but it's not so bad. It's not so bad as the rhabdomyolysis. And elevation, a twice elevation of normal value AST is tolerable. It's not important. But muscle weakness, muscle pain is super important because translate rhabdomyolysis. Client collecting 24 hours urine, ask the nurse for instructions after spilling a small amount of urine when pouring it during the last hour collection. What instructions should the nurse give? What is the answer to this question? I put this as in your final thing.
Little c.
You need to start again, new collection. Throw away that and you need to start again. Okay? No matter that you feel frustrated, you need to start again. Because any drop should be spilled because then it is going to affect the results. The nurse is providing education on newly prescribed fluoxetine. Fluoxetine, brand name Prozac. SSRIs, okay, selective serotonin reuptake inhibitor for depression. We already talked about this. It's in the same family as a paroxetine, sertraline, okay? But also is in the family of the citalopram. That doesn't sound similar. What should the nurse include? So that apply. So you are providing teaching. The patient is starting the medication. Take before going to bed, yes or not?
No.
No, because it's a stimulant can produce insomnia. Take in the morning with a breakfast. Decreased libido and delayed orgasm could be expected, yes or not?
Yes.
Yes.
Yes. There is an increased suicidal risk, yes or not?
Yes.
Yes.
Yes. Muscle stiffness and elevation of temperature are expected, yes or not?
No.
No.
Oh, it's a complication. In this case, what you can have is serotonin syndrome that could have muscle stiffness and hyperthermia. The same as the neuroleptic could produce neuroleptic malignant syndrome, but in other kind of client. Mood improvement can take weeks in develop. Yes or not?
Yes.
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 1 to 3 weeks. Okay. Sometimes a little more. Client arrived to the ER with headache, fever, and photophobia. This is an scenario of meningitis. The nurse suspects meningitis. What should do next? It's the same what you do first.
C.
I agree. You need to initiate isolation because you are in the ER and it's very difficult to isolate a client while is in the ER. The best intervention for clients arriving with need of isolation, airborne or droplets isolation, is to put a mask in the client while you find a room for isolation. Should be a regular surgical mask. Regular surgical masks are more efficient to filter from in to out than any other. Particulate respirator, or which is the same as N95, is to filter from outside to inside, from out to in. But to filtering from the lung of the client, from the mouth of the client out, is better a regular surgical mask. Okay. The nurse is supervising care given by the nurse, by the new nurse, to a child with RSV infection. RSV, respiratory syncytial virus, the same that produces bronchiolitis. The nurse should intervene if the following is observed. Nurse leaves the room, leaving the door open. Nurse measures the blood pressure without wearing gloves. Nurse administers respiratory therapy without wearing mask. Nurse rejects the food tray because it's not disposable. What is wrong here? What you need to intervene?
B as a boy.
B as in boy, you need to be wearing gloves because it is contact precaution. You must wear gloves because in contact precaution, you must wear gloves all time when you enter the room, gowns and gloves. If it were a standard, there is no problem checking the blood pressure without gloves, but this is not a standard. It is contact precaution. Home health nurse is irrigating and changing dressing of a client with a surgical wound infected with vancomycin-resistant enterococcus. Which PPE should the nurse wear? Select all that apply. Let's see, yes or no. Face mask, yes or not?
Yes.
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 Gloves,
Yes.
yes. Gown,
Yes.
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 goggles,
No.
No.
yes. If you have a splash in your eyes, what is this irrigating? You are irrigating. And if you have a drop of vancomycin-resistant enterococcus falling in your conjunctiva, now you are going to be called la tuerta. ¿Y ella qué le pasó? ¿Qué le pasó a la tuerta? Ay, she forgot to use goggles. She forgot to use goggles, okay? So don't forget that because you need to pay attention that you are irrigating. When you irrigate the wound, you anticipate a splash, okay? Suctioning, irrigation, those kind of stuff, you anticipate splash in your eye. Particulate respirator for BRE? No.
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 Antibiotic of choice to be ordered in client with inhalation anthrax.
C.
Ciprofloxacin. Ciprofloxacin. Okay. Ciprofloxacin. Okay. An alternative is tetracycline. Which of the following pregnant women should the nurse see first? What is more concerning here? 28 weeks with uterine contraction before entering the bladder, 36 weeks with preeclampsia and blood pressure 140. 39 with contraction every 10 minutes, 34 weeks with epigastric pain. Which one is the priority here?
D.
Yes. When you see epigastric pain in a pregnant woman, this is the priority. This is a sign of severe preeclampsia. It's a symptom of severe preeclampsia. Bipolar client taking lithium, which finding requires immediate follow-up. Client has difficulty holding cup because hand tremor. Client has difficulty falling asleep and feels anxious. Client complains of frequent travel to bathroom to urinate. Client is consuming pickles and H's.
A as in apple.
A as in apple. I agree. I agree. Because the symptoms are progressive. First, nausea and vomit. Nausea, no? Then the usual fine tremor become gross. And then the patient has difficulty doing the ADLs, like, holding a cup, spoons, etc. And then is when appears the ataxia. So the patient have loss of coordination of the movement and even can have difficulty to walk. And of course, the speech becomes very slurred. And well, the polyuria is early, but it's expected, no? It's something that could be normal. Usually when there is polyuria, which is an early sign of toxicity, they reduce the dose to once daily. So fine tremor and polyuria is not necessarily something serious. Fine tremor, but coarse, incapacitating tremor is concerning. A lot of nausea and vomit and diarrhea also is concerning. And ¿qué otro es concerning? Okay. Of course, if the client has ataxia, it's very concerning. Okay. Pickles and HSS are rich in sodium, so it's good. It's good for lithium. Okay. This is because the disease, falling asleep and feels anxious. Okay, this is because the disease. It's not because the medication. Okay, so lithium. A couple decided vasectomy. No, a couple decided vasectomy was the alternative to control fertility. What recommendation should the nurse give after the procedure?
C.
Yes, wear condom until the sperm count is 0, because weeks after the vasectomy, you still have a store sperm in the seminal vesicles that could impregnate an egg. So the answer is this. The only way of knowing if you are already 0 is the spermatogram. Okay, is the only way to verify that. A client is admitted in outpatient surgery for vasectomy. Another question, vasectomy. When the nurse starts preparing the client for the procedure, the client states he doesn't want to go on with the surgery. So change his mind, have a second thought. Which is the best statement by the nurse at this moment? When you have signed the consent, you can go back. It is not true. I can rule out that. Okay, it is not a comunismo. You have the right to withdraw the consent, but you need to talk to the physician. No, you don't need to talk to the physician. This is a condition that I disagree. But you need to talk to the physician. No. I will tell the physician, but you have the right to withdraw the consent. Okay, so you don't need to talk to the physician. Are you concerned about your sexual performance at the procedure? You seem worried. Would you like me to call your wife? Which one is the best?
C as a cat.
Yes.
D. Oh, C.
You cannot do D because te estás metiendo en lío. You are introducing an element that could be, imagine that they agree, man and woman, to have the vasectomy, and then he had second thought. And the one that can inform that to the wife is himself. So when you call the wife, okay, it is introducing a problem there. It's better to talk to the client about, okay, what the concerns are, and to let him know that he has all the right to cancel the surgery. But you would like to have some conversation. If I were in my test, I choose C. But I'll never call the wife because se va a armar un lío ahí, una pelea. And remember that is the privacy. The patient has second thoughts. The patient maybe wants time to think. And in this moment, the wife should not intervene, should not influence. Is the client alone without the wife, and vice versa applies to the wife, the one that needs to have time to think and to decide without pressure. I never call the wife. Never. This is a decision that he needs to take, not from me as a nurse. So the only that I consider that is not harming is C as in cat. D is harmful. A and B are illegal. Okay, I'm going to have this at last because I'm tired. What is the most important consideration to be included in the care plan of a patient that is going to surgery? Weighs 360 pounds and is controlled for diabetes mellitus and hypertension. So what is the most important in the care plan of this client, of these 4 options? Finger stick blood sugar monitorization, blood pressure measurements, client transfers and mobility, wound care schedule.
C.
C as in cat.
Yes, the most concerning here, the one that is not routine, is the weight of the client. So transfer and mobility is the most important aspect of the care plan to consider in this client, how it's going to be transferred and moved. Because the other is routine. A diabetic, we're going to have acute checks. A hypertensive, we're going to have blood pressure measurements. And any surgery requires wound care. But what is different in this client is that this question has been many times in several students, okay? Okay, guys, I need to work early tomorrow, so I'm going to stop here, okay? So any question, any suggestion? Are you good?
No, Professor, thank you so much.
Are you studying a lot?
Thank you.
Are you taking
Oh, a
time
lot.
to study a lot?
A lot.
Pero
Yes.
de verdad, honestly, okay? Okay, okay, guys. God
Yeah.
bless you. See you on Thursday, okay? Thursday.
Yes.
Okay,
Thank you.
bye-bye, bye-bye.
Thank you, Professor.
Thank you. Ok, ¿qué tengo que hacer? La attendance. Que no veo. ¿Qué es lo que me falta aquí? Dios mío. Aquí es la cosa, Dios mío. Cada día estoy más inútil. Ok, aquí es. Aquí. Listo, ahora sí.